Okay, hello everyone, and thank you so much for joining us. So this webinar is all about Eating Disorders Awareness Week, and we are in conversation with Beat. So my name is Kat Nicholls, and I'm a writer here at Beat. No, not here at Beat, here at Happiful. But I am also a volunteer at Beat, and we are going to talk about that a little bit more as we go on. But I've been joined here today by Kerri Fleming, who works at Beat, and also Dr Gregory Warwick, who is a chartered counselling psychologist and a member of the counselling directory as well. So I'm going to let those two introduce themselves before we get into it. So Kerri, could you kick us off by telling us a bit more about yourself?
Of course. Hi everyone. Thanks so much for having me on this evening. I'm really looking forward to having some of these discussions. So my name is Kerri Fleming. I am the head of specialist services at Beat, and I'm also a registered mental health nurse. So I moved into the charity sector about a year ago now, after working kind of face to face with eating disorder patients for about 6 or 7 years. Moved into the charity sector to try and kind of keep that, passion for eating disorders going and keeping the conversation happening, and Beat's been a great place to do that. So I'm looking forward to this evening.
Perfect, thank you. And Greg, yourself, can you tell us a bit more about yourself?
Yeah, hi everyone, I'm Dr Gregory Warwick. So as mentioned, I'm a chartered counselling psychologist. I run a service in Salford, Manchester called Quest Psychology Services. I've been a psychologist for about 5 years and was in counselling sort of probably for about the last decade. And I came into eating disorders within my training, and I used to work at an outpatient service and then started working within some inpatient services in some private hospitals. So had a bit of experience with it.
Absolutely, that's brilliant, thank you. And before we get started, I really wanted to give a little bit of context as to my personal connection with this, because I actually had anorexia in my teen years, and I was very fortunate that I got support pretty early on. And I went through the NHS and I got support there and went through counselling and therapy. And I've now been in recovery for kind of almost 15 plus years now, which is brilliant. And I now work as a volunteer for Beat, and I do the shared peer befriending service. So this is where I email with young people who are currently living with an eating disorder to just be a bit of a listening ear, and as someone who has been out the other side and has been through it and understands it. So that is my role with them. And yeah, obviously I work for Happiful as well as a writer. And yeah, this is a cause and a charity very close to my heart. So I'm really looking forward to getting into this. So we're going to start by looking a little bit more into understanding eating disorders, because there can be so much misinformation and misconceptions out there around them. So I thought it could be quite helpful to get a bit of an overview about what they are and how they can affect us. And Greg, I'm going to come to you for this to see, if you can give us a little bit of an overview of how eating disorders can affect us.
Yeah, definitely. It was a question I was thinking a lot about before coming on tonight, because I think for a relatively simple question, there's a really complicated, long-winded answer. So I suppose we all kind of have different relationships with food. We have things we like and don't like, whether that's smells, different types of foods, textures. And I guess when we think about eating disorders themselves, it's when that behavior around food gets to a point where it causes us sort of significant emotional distress. It starts affecting our day-to-day life, and not only does it impact our mental health but also our physical health as well. So I think a lot of the people who've logged in tonight are probably pretty familiar with some of the more well-known eating disorders like anorexia, bulimia, binge eating disorder, and you can kind of check out some more of the definitions on Beat, because they've got other eating disorders like pica that aren't as well known, or even things like offset, which is other specified feeding or eating disorder. So I guess when I say it's kind of quite complex, it's because I suppose we've got all this diagnostic criteria and they overlap with one another, and that makes it quite difficult to distinguish between each one. And then you've got each person's individual experience. It's going to be slightly different anyway, to kind of murky the waters a bit. So I guess in general, eating disorders are characterized by a restrictive diet, patterns of binging eating, sometimes purging and compensating for the food that's been had. And then that's all in addition to kind of the effects on our mood and relationship with our own body. So when you boil it down, I guess one model of therapy called CBTE, they would state that all eating disorders could come from an over-evaluation of shape, weight, and control. And then that's displayed in some of those behaviors like the restrictive eating, patterns of binge eating and purging and compensating. So it's really quite difficult, but there's a lot to it, I think.
They're definitely complex mental illnesses, and there's a lot that goes into it, and they're not often necessarily about the food. Like the food is kind of almost a symptom of everything else. So yeah, thank you, that was a really helpful overview. And Kerri, can you tell us a little bit more from your experience about some of the common maybe myths around eating disorders?
Of course. I think it was actually hard for me to kind of think about just a couple of these, because there's so many out there, and over the years that I've worked in eating disorders, I've heard some absolutely like mad things that people believe are accurate and true, and even in professional world we hear these things. So I kind of said I'd focus on a couple that I think maybe some of what the viewers here might have heard and kind of understand as well. So there's a lot of misconceptions out there. Some of the more common ones are that, for example, someone with an eating disorder is always underweight. Sadly, this is a stereotype that often prevents people from realizing they have an eating disorder or feel like they are kind of worthy or deserving of support for their eating disorder, and it can mean they don't reach out for help. It also might mean that maybe carers or professionals that are involved in this person's life might not recognize it early either, and obviously early intervention is something that is really, really vital in eating disorder recovery. You can't tell if someone has an eating disorder just by looking at them. Eating disorders are extremely complex, like you mentioned, and they impact people of all weights, sizes, genders, and backgrounds. So that's something that we are quite vocal about, and that weight, as much as it's in the diagnostic criteria, like Greg said, there is so much more to an eating disorder than just that. Another quite common one is that eating disorders are female illnesses. It is quite more talked about kind of in female teenagers, but in reality, we estimate that about 25% of people with eating disorders are male, which is like a quarter of all the people out there with eating disorders are likely to be male. This number is likely to be much higher than we even realize because of the stigma around men reaching out for help. We've been, I guess, seen in the media kind of recently, some more males coming forward, kind of celebrity males coming out with their experiences, and that's really helped for more men to speak out as well, which has been really, really, really good, and that's helped breaking down that misconception. And I guess another one, kind of carrying on a little bit from what Greg said, is that anorexia is the most common eating disorder. We see the word anorexia thrown around a lot. We see it in the news, we see it in newspapers, we see it, people mention it a lot more than anything else. But there are so many different types of eating disorders, and binge eating disorder actually impacts more people than anorexia and bulimia combined. So last year's Eating Disorder Awareness Week was based on binge eating disorder, and we've seen a big increase in that over the last 12 months of people coming forward with my God, that's what I've been struggling with. There's finally a name for it, or like a title for it, and it helps. So I think it's important that, despite there being all these misconceptions, that just do proper research, reach out to kind of professionals and people who have maybe lived it and experienced it, kind of, you know, experts by experience as well, that might have more information for you if you're unsure about anything when you hear it about eating disorder.
Thank you for sharing those. I think that's so true, and I love that Beat are so vocal about the different myths and trying to get people to understand, especially around the weight issue. And yeah, that's something we definitely talk a lot about at Happiful as well, and trying to bust those myths. So now we have a better understanding of eating disorders as a whole, I'd love to dig in more to this year's Eating Disorders Awareness Week campaign. So Kerri, can you tell us what it is that Beat are focusing on this year and why?
I can, and it's a really, really exciting one, and it's great that we have a theme like this that we're able to do. So this year's Eating Disorder Awareness Week has its focus on medical professional training. So we're campaigning for every medical school and foundation programme to provide a comprehensive eating disorder training as part of their degree. Our aim is to help ensure that every future GP is able to understand eating disorders, spot the signs much quicker, signpost people to the right and most relevant treatment. Recovery is possible, but we do rely quite heavily on our GPs to spot these early warning signs. That, again, may have nothing to do with weight or appearance. We recently carried out a survey a few weeks back on people who have experienced an eating disorder, and 58% of those that responded felt their GP didn't understand their eating disorder. 72% had to wait over 6 months to get help from their GP. One of the main reasons we've put this campaign as kind of the focus of EDAW this year is that through no fault of their own, the average GP receives less than 2 hours of eating disorder training during their medical degree. A fifth of UK medical schools don't provide any training at all, which to even try to comprehend that, given there's over 1 million people in the country struggling, let alone carers being impacted by this as well. We know that GPs are extremely dedicated to supporting these people, but they have to be given the tools that they need. Their role is really crucial. Their responsibility is huge. So we are voicing this campaign and putting that out there to help support with this going forward, that we can help all future GPs that are being trained up to gain an understanding and knowledge of eating disorders, to just help as many people as possible be treated as soon as possible.
I think it is such an important one to cover, and I love that Beat are sharing different experiences of people's experiences with the GP and going through the NHS. And it prompted me to think back to what I went through when I was, obviously this was many years ago, this was a good 15, 20 years ago now. But I remember going to the doctor wasn't about my eating disorder. It was actually my parents took me because they knew something was up and they just wanted me to kind of usher me in front of a professional so that they could figure something out. And luckily they could see that something was wrong, and they referred me to counselling straight away. And I didn't actually want the support for the eating disorder at the time, which is quite common, I think, with people with eating disorders. You don't think it's a problem, you think you've got it all under control. But what I did want help with was the depression and the feeling really low. So I was quite willing to go to counselling. I was like, oh, maybe they can help me feel a bit better. And then through the counselling, that's when I started talking a bit more about the eating problems that I was having. And that was when I realised, if I want to get help for this depression and the low mood, I'm going to have to look at this other thing over here. And that was really the turning point in my recovery process, as I realised I wanted to feel better. I didn't want to feel this way anymore. And I just thought that was so great that the GP spotted that something was wrong, and they didn't necessarily know it was an eating disorder at the time, but they put me on the right track. And that counsellor then referred me to a specialist. I got into with a specialist, and yeah, the rest is history. That's how my recovery started. So it is great to see the positive experiences, but we know also
Definitely.
there are some negative ones as well.
Because it's not, we are very much aware that it's not the GP's fault. GPs, honestly, they've done so much over the past 2 years, particularly during COVID. It's been obviously the numbers of people presenting with eating disorder behaviours and kind of the effects of that on families has been really, really seen much more over the last couple of years. And GPs have done an amazing job of trying to manage this and on the front line. So I think we're looking at other things in the future, kind of the later 2022 of training for current GPs. That's an ongoing thing that Beat are doing as well. I think that is something that we're really proud of and really looking forward to get off the ground and get running. So the campaign itself is, I guess, for future GPs, and something that we're hoping just becomes ingrained and becomes normal, that eating disorders is talked about at an early stage of a medical degree, really.
Yeah, that would be so fantastic. It'll be such a support for people. So how can anyone watching get involved with this year's campaign? What can they do?
So we're really grateful for the dedication of our supporters. We're always keen to hear from people who want to get involved. This year, we have a bit of a slogan for people who want to get involved. We want them to speak up, skill up, and step up. So we would like them to speak up by sharing their positive or negative experiences with GPs on social media, with their family and friends. Get that conversation going. Get the conversation out there of what they've experienced. Don't be afraid to talk about it, good or bad, and just share that knowledge with other people. We're asking them to skill up by joining our campaign online for change and showing why it is so important that our future GPs will be better equipped to make these life-changing interventions, because that's what it is. The earlier intervention can be life-changing for people. And we're asking them to step up by fundraising for Beat, to amplify our call for proper training on eating disorders. You'll see us using various hashtags over the next, I guess Eating Disorder Awareness Week starts on the 28th. So from now, for the next few weeks, you'll see us use hashtags, hashtag worth more than 2 hours and hashtag EDA2022. So if you are getting involved in any way, whether that's spreading the word or looking at fundraising, please utilize those hashtags, and we'll be able to share them with all our followers as well.
Brilliant. And of course, if anyone can campaign and fundraise and donate to the cause as well and help make this all a reality, that's something fantastic they can do. And am I right in thinking there's a theme about being bold and bright for BEAT as well?
Yes, be bold and bright. So you might see that our posts this year are very colourful, as our website always has been anyway, but we are saying if you're going on a walk, to a sponsored walk or anything like that, dress up, be as colourful as you can, be bold, be brave, be bright. Speak up really and feel confident in what you're saying, and just kind of be noticed. We want this campaign to get recognised. We want this campaign to be taken seriously, and it's doing so well already that we're hoping everything that we do during EDA just helps further that more. And the more colourful you guys can get, I'm sure the more people will get joined in as well.
So we've mentioned a couple of times about the importance of early intervention, but it'd be really great to get an understanding as to why this is. So Greg, it'd be great to know, why is early intervention so important, and how can people start that journey to getting the right support?
Yeah, definitely. I suppose it's an odd one when you think about where the two kind of meet from, like mental health and physical health on this side. So I guess from a clinician's point of view, when we're managing risk, there are things that we look out for in people with various different mental health problems. But it's quite different when it comes to eating disorders because, and I think that adds to the sense of urgency sometimes. So, just the impact it can have on someone's physical health. So we all need to eat within a certain limit to survive, and whether it's too much or too little, we can become quite unwell. The other thing, and it's not nice to talk about, but I suppose sometimes with the compensatory behaviours, like making ourselves sick or using sort of laxatives or diuretics, it can create medical emergencies. And in worst case scenarios, things like heart attacks are a very real kind of concern. So I think there's a sense of urgency with that. The other reasons why earlier is better in this case is, I suppose, with we're ultimately trying to change habits, aren't we? Trying to change eating habits and how we look after ourselves. And the longer that goes on, it kind of embeds itself a little bit more, and in particular with people who are sort of significantly underweight. So that's really useful from the early side of things. I guess in terms of getting the right support, for me, I think choosing your source is really important. So there is a lot of stuff out there on the internet. There's going to be a lot of stuff on TikTok. There's going to be a lot of stuff everywhere about what's right, what isn't right, what is an eating disorder, what isn't, how you should manage it, how you should lose weight, how you should put on weight. So choosing your source, I think, is probably the best thing I can think of. So using, the NHS, charities that are registered for eating disorders, real sources that provide evidence-based kind of information, because I think the worst start you can have, which sometimes maybe delays that intervention, is having the wrong information sometimes. So I think that's really important.
Definitely. And I think what you mentioned there about the physical side as well, it's definitely important. And it is all about habit change, and the earlier that you can get support, the earlier you can start turning this around. Because when you've been living with a habit and a certain way of thinking and behaving and eating for so many years, it becomes more difficult, not impossible, but more difficult to change. So that is super important. And if someone was looking to try private therapy, for example, can you tell us a bit more about the different therapeutic approaches that can be supportive, and maybe what people should be looking out for a private therapist?
Yeah, definitely. So I suppose NHS and charity options are certainly viable. I think they are, useful for anyone. So if you've got access to that and then it's in your area, and getting on that waiting list is perfectly fine. I don't think private therapy has to be a route that people take. It's usually an option people go with because often we can see people a lot more quickly than some services because we're not as overloaded. Sometimes I guess there could be barriers to going private. So if someone was particularly underweight or engaged in risky behavior, that might make it more difficult to see a private therapist, because you might want a team around that person to help, manage their care really safely. Like in Kerri's profession, like nurses, you might want nurses, you might want psychiatrists, OTs, people that can stay and help sort of all around the clock rather than just an hour a week is what people in my position would normally do. So there are options like private hospitals if people need to stay. So things like Signet, the Priory, Nuffield Health. They're all kind of options for private. Alternatively, I suppose if someone's well enough or safe enough, they can look for private therapists. So that could be a therapist, a counsellor, a psychologist, on websites like the Counselling Directory or Psychology Today are good places to start. And they're good because they check that people have got the right qualifications. So, you know, when you're looking for someone, you want to check that they're either like registered with the BACP, the UKCP, the Healthcare Professions Council, because the last thing you want is someone who's not qualified to help when you're in a bad place. I suppose if you were working with maybe vulnerable people or young people, you might want someone who's DBS checked. So they've gone through a disclosure and barring service to you know, check their background. And I guess when you think about individual people, then quite like in line with the topic of BEAT's campaign this year about raising awareness for the professionals, I suppose, I think a lot of people think just because we're qualified psychologists or counsellors that we have eating disorder training, and that's not the case. So people choose to specialise based on their placements or where they choose to go in terms of courses afterwards or where they choose to work. So I think if you want the best help, you're going to want to find someone who's had that experience of working in that area, because it's just because you're a counsellor doesn't mean that we know that stuff. And then just thinking about some of the models you might want to look with. So there's things like CBTE, which is for a specific type of eating disorders therapy under CBT. And then there's other evidence to suggest sort of like dialectical behaviour therapy or EMDR are usually quite good. And depending on what that person needs, depends on what they might go for within that, whether that's managing the emotions and that leads to eating problems, might be DBT. If it's a specific event that's caused it, you might go down the route of EMDR. But regardless of the model, 40% of all change comes from that relationship. So you've got to be getting on with that person to make it work. I was wondering, Kat, because of the experience you had through, you know, going through the NHS, having that experience, if you had one sort of factor or tip that you would want in choosing someone, what would you say to people? What would that be?
Yeah, because I didn't get to choose. I was just sent to someone. I was sent to a specialist, and thankfully I did get on with them, and it all went well. But I have since then had therapy for other things, and I think you're right. I think getting to know the person is really important, and understanding a little bit more about the way they work and making sure you gel with them is super important. I know that's why on Counselling Directory we so encourage our members to write a bit more about themselves and share a bit more about their approach on their profiles with us, so people can get a bit of an understanding of that. But yeah, I would say that's probably the most important thing I would look for to make sure I feel comfortable, because you're going to be talking about things that you probably haven't even talked about with your nearest and dearest. Like, I hadn't spoken to my family about the problems I was having when I was speaking to a therapist about it. And yeah, just having someone and knowing that they had my back was really, really important.
Yeah, definitely. I sometimes wonder, and I think it's more on individual choice, because again, we're talking a lot about physical health stuff. So when we come to kind of eating disorders, and you know, for some people, that largely revolves around kind of like their body. We might be talking about kind of risky things or physical health problems, like if people's periods stop. So I think as well, maybe giving a bit of thought to sort of genders could be helpful as well. I don't think it's a factor that kind of, well, the research shows it doesn't change kind of the outcome of therapy depending on if you and your therapist are matching in gender, but I think for some people it might make them feel a bit more comfortable.
Yeah, that's so true. I think, yeah, making sure, yeah, you're comfortable. And there's also like LGBTQ counsellors who can provide a lot of support and just might understand where you're coming from a little bit more depending on your situation. So that's a very good point.
Yeah, we actually have recently had someone who was looking for someone of the same religion, because they were going to be going through Ramadan and going through Eid. And obviously it was something that my knowledge wasn't where it should be on it. And it was really interesting. So that was one of their, I guess, choosing factors of who was their therapist, and it was so important because I never even considered that. And I think if you have a preference of something, don't be afraid to look for that if you have the option to do that, because it's just so important.
Definitely. someone in the chat at the minute is talking about kind of autism and how that links in sometimes with eating disorders, and I think a lot of people don't realize you can also search for people who are, neurodivergent and sort of different levels on the autism spectrum, and might help some people work out kind of, is this a sensory thing or is this an eating disorder? Where does that lie? Because it's quite difficult to pick apart. So having someone, we talk a lot about experts by experience and lived experience. That's always useful in that domain too.
Yeah, absolutely. I'm just going to catch up with the chat, actually. Thank you, everyone, for sharing your thoughts on this. Yeah, everyone's saying it's a great campaign. Some people are saying they haven't had support yet, and Emily has shared the Beat helpline there, so if you are looking for someone to speak to, please do give them a call. And yeah, somebody said, my GP, Beat and my treatment teams, I'm very fortunate that have saved and changed my life, so that's amazing. Thank you.
I think it's important to share those positive experiences as well, because I feel like everyone finds it easy to share the negative ones, and it can make people, I guess, kind of more reluctant at times to get help. So I think it's nice to have that balance of the good and bad experiences, so people can choose what they need to do next.
Yeah, absolutely. And I would say to anyone watching as well, is if you have any questions as we go through, I see we've had one, do pop it in the Q&A box here, and we're going to leave a little bit of time at the end to go through them. So we will come to your questions, I promise. Okay, so moving on a little bit more to other avenues of support. I know Beat obviously provide a lot of options. So Kerri, it would be great if you could share, as well as the helpline that we've mentioned, what are some other services that Beat provide?
So we provide a lot. We have stuff specifically for people with eating disorders and their carers. So I'll kind of talk about both. So for those with an eating disorder, as mentioned in the chat already, we have our helpline. So it's confidential, it's friendly advice to those impacted by eating disorder. So that can be whether you're struggling with yourself, whether you're a carer for one, a professional, regardless. If you're impacted by one, please do call up and we can give you some support. It's open 365 days a year, 9 a.m. till midnight during the week, and at the weekend it's 4 o'clock until midnight, and bank holidays as well. On our website, so if you had a look at our website, it's www.beateatingdisorders.org.uk. We have a lot of online support groups. Some of these are quite specific. So we have, for example, one for just binge eating disorder. Then we have some that are kind of open, like each evening there's one where you can join regardless of your eating difficulties and just get to speak to other people. They're moderated by some of our advisors, which are really useful, and they share ideas. So if you take a look at that as well, there's a lot of stuff on our website. On that, for carers, we are, part of our strategy over the next few years is kind of looking at the whole family intervention as well. And we know that caring for a loved one with eating disorder can be very difficult and isolating. So it's very important that carers have support for their own mental health as well as their loved one. We recently launched a really, really amazing resource called the Pod. So it stands for Peer Support and Online Development. It's designed to support people caring for a loved one with an eating disorder. That includes parents, partners, families. We've had siblings on there. We have school professionals on there. Anyone that cares for someone with an eating disorder. It is an amazing resource. It's a platform where you can learn about eating disorders, get advice and support from eating disorder experts, connect with others in similar positions, all in one place. There's like modules you can read through, videos, workspaces, there's forums, there's chat rooms where you can just link with other carers that are going through similar things to yourself. I think from studies we've done in the past, carers benefit a lot from other carers' experiences. And I can see in the chat there is a lot of carers here and kind of saying the experiences that they've had with their loved ones. And there might be other carers that would like to hear those experiences as well. So please do look at our website and have a look at the pod and see if you'd like to sign up and access some of those educational and also just kind of chat-based functions, which are really, really useful. There's also on our website a letter you can bring to the GP that will help you explain the situation. So you might have a loved one who is struggling to kind of verbalize things or not know how to say it. Maybe you don't understand it well. So there's a letter available on our website as well that you can download and bring to the GP with you to help kind of get your point across of what you're concerned with, or at least start that conversation. So there is a lot that we are able to offer, and it's all available on our website.
Yeah, that's fantastic. I think the letter, that is going to help so many people. I can imagine if I had that when I was younger, to take that to the doctor, that would...
Yeah, you can just literally hand it to them and that conversation started for you without you having to say anything, which is, I think, really, really beneficial for a lot of people out there.
Definitely.
Yeah, and I remember something that really supported me when I was going through my recovery was just hearing other people's stories. I don't think I actually knew about Beat back then. Again, this was many, many years ago, but I do remember finding people sharing their stories on some websites, and I remember reading other people's stories. I bought books about people who had gone through it, and it just makes you feel so much less alone, like you're not the only person with these thoughts going through your head. And it just, it's amazing. Yeah, as Emily said, the stories section on Beat website is fantastic. And Emily also says creativity boards and journals can really help have those conversations too. I love that idea, Emily.
That's it, and that sharing those ideas is so important. That's why the online support groups really people benefit from them, because people share things that they've done and that have worked and that have helped get what they need to across to people as well. We also have our social media, of course, which is monitored so that people can message us through social media. So we've Twitter, Instagram, Facebook. People can message us through that as well, which is really, really, I don't know, I guess a modern way of reaching out, alongside our web chats and emails and stuff like that as well, if you're not feeling too confident picking up the phone. There's kind of virtual ways of contacting us as well, which is all available through the website as well.
Yeah, and that's great. I can imagine. I'm a proper millennial. I hate phone calls. So
I hate phone calls, and it's my job. I work virtually, and it's like, oh my god. So I completely, when I see a web chat option, I'm like, yes. So I can imagine it's a great option for people if they struggle at all with that.
Yeah, definitely. And I can see my colleague Lucy has popped in the link to the GP letter there as well, if anybody wants to get that down. Okay, so I think we're going to go to some questions now. So we've had a few in, so let's start with the first one, which is, when would medical professionals become concerned with someone with eating disorders physically? Does the person have to be severely deficient in nutrients before they get any help? So I don't know who wants to maybe take that. Does anyone know anything about how medical professionals would start to become concerned about the physical wellness of somebody with an eating disorder?
Could maybe add a few things, and Kerri can fill in with her nurse knowledge where I don't.
Yeah, that's a good deal.
Okay. So I suppose, when I initially get a referral, regardless of the level of concern, we tend to make a GP referral, and you do that whether you're sort of in inpatient services, outpatient services, or a private clinician. So what we're looking for, we need a range of things. So there are things that you might be concerned about someone's physical health, from telltale signs such as like whether someone's periods have stopped, whether there's a brittleness to someone's hair and fingernails, which gives sort of a degree to how they are sort of nutritionally. We would want them to do a liver functioning test to sort of check kind of how the body's organs are doing. So from blood work, having a look at kind of how they're doing, and you look as well, just as a sort of preventive measure to check everything's functioning as it should be. And I suppose someone's weight, obviously, there is a focus, I suppose, sometimes on underweightness, and it's not to say that it's not a concern the other way, but I think when we think about physical health, there's a sense of urgency with people who are particularly underweight. So you're looking for people who are lower on the BMI scale. It's not a foolproof measure, because for people who are particularly muscly, it doesn't work out very well. But people who are quite low, we get more and more concerned about. And if they're lethargic as well, if people haven't got the physical energy to get through their day, that's obviously a concern too. What have I missed out, Kerri?
And just reading through the question again to see if there's anything that we missed in particular. I guess, does the person have to be severely deficient in nutrients before getting any help? I guess unfortunately it depends. I guess if you're going through the NHS, some areas might be have more capacity to take to prioritize people who may not be at immediate risk. And that shouldn't be the case, but of course the demand is really high at the moment, so the person might not necessarily have to be really deficient in nutrients for any help, but in some areas, if there is a lot of people presenting at the same time, they might prioritize those that have more physical signs of deterioration, unfortunately. So it's hard to kind of put a quantifiable number on that, really.
Definitely. There was someone in the chat before that said that they've been waiting many years for a diagnosis, and I think that comes a little bit into what we're talking about now, is it? Diagnostic categories are really useful for people to talk about labels, but they are just a label for a series of symptoms. And if you do or don't have one, that can be really invalidating for what you're going through. But unfortunately, it is the kind of to get through the gates for a lot of services, because as Kerri just said then, some services in maybe your local areas aren't as well funded or have the capacity for people. So it doesn't mean that you're not going through something really significant, but there is unfortunately a bit of a threshold when we think about concern and the speed at which people get seen, and unfortunately that might be the reason why someone goes private, because whilst it does cost money, there's no gatekeeping and it's a speedier process.
I agree. So it's, some people may be more deficient than others, but I think it depends on the availability of services in anyone's area, and what that level of deficiency might be.
Absolutely. Thank you both, and thank you for mentioning about the diagnostic criteria being not the best, because I remember feeling very invalidated myself when I went through and I didn't meet a certain threshold. There were certain symptoms I technically didn't hit, and in my mind at the time I was like, oh, okay, then I don't need help, then I don't meet this. I've failed as somebody with an eating disorder. There's so many things that can go through your mind. So definitely, I do hope one day they change, and I do hope one day they take into account the mental side of it as much as the physical side of it. But we're getting there slowly.
Definitely. I think as well, like, and that changes with time, as Kerri said earlier about Beat's campaign last year being about binge eating disorder. I think with culture, we're changing that as well. So when you think about diagnostic categories, before, unfortunately, binge eating might have just been seen as like gluttony, because it's not understood, and we're slowly getting that way. So I think we're actually due a new diagnostic and statistical manual revision in the next, I think, half a year. I think it's going to come out. So it'll be interesting to see if they change any of the criteria again. And the Europe's version, called the ICD-10, is about 11 years old now, so that should be due soon as well. So
I think it is. I think they're doing something with it at the moment.
Yeah, so it'll be interesting to see how they change, because things like EDNOS was taken out, so eating disorder not otherwise specified, and now we've got all different ones. So they do change.
They do change. This is good. Brilliant. So let's move on to the next question. So this person says, I am a counsellor on the directory. Oh, brilliant. Hello. Since COVID, I'm finding an increasing number of my clients who are presenting with disordered eating issues. Body dysmorphia is becoming increasingly common. Is there specific training offered from BEAT to counselling professionals? So Kerri, I'll come to you on this one.
Yes, we do have one course. It's called Beyond the Symptoms. It is, I guess, aimed at, initially primary care, but we have had a lot of wider medical professionals, psychiatric professionals take part in the programme. But I think it has to be funded in your local area. So it depends on those kind of varieties. But if you take a look on our website, so it's called Beyond the Symptoms, you might be able to see if it's available in your area, or if there was, if you had any scope in your area to kind of look at funding at, a certain amount of professionals, and things like that. It's something that is really, really popular and taken up quite a lot across the 4 nations of the UK, which is great, because it's showing that there is, medical professionals out there really wanting to learn and wanting to know about it. That demand, you're completely right. Since COVID, there is an increase, and it's undeniable. So we're seeing an increase for the want for that service as well. So it's a positive thing. It's obviously sad that there's more people presenting, but it's also getting the knowledge and training out there. So please take a look on our website and see if it's something that's available in your area, or if there's something that you could look at supporting.
Perfect. And I can see my colleagues, Lucy has popped the link in there as well for Beyond the Symptoms, so please do check that out. Great. So the next question is there any hope for moving away from relying so heavily on BMI as diagnostic criteria in services? So yeah, I think we have covered that briefly, but we are hopeful, right?
Yeah, I don't imagine they'll move away from it as much, so unfortunately. I think
not as much as we probably like them to. I think there's rationale for why it's there, from a risk perspective and a monitoring perspective as well. I think even if it does remain, I think what's important is increasing the importance of the other elements of that diagnostic criteria, and it'll be there and it will be diagnostic criteria, but I guess having equal importance across all the criteria, not just so much on the BMI. Like you said, they're kind of relying so heavily on it. It will always likely be a factor, but I think what will happen over time with everything that we're doing and everything that you guys out there who are attending all these like amazing webinars and kind of getting the conversations going, there will be more conversations around those other things that form that complex mental illness, which will be taken into just as much consideration as the BMI would be, is what I think will happen over the next few years anyway.
Yeah, I think it's difficult because depending on what you define as diagnoses, because you know, when you look at the manuals for providing a diagnosis, you know, that isn't a structured assessment of it. It is someone's opinion as to whether or not you meet those criteria. So it's quite a working diagnosis rather than a clinical diagnosis. So and that's again coming back to sort of service time, because people don't have kind of an hour or an hour and a half to go through a screening assessment to work out where exactly people lie. So I think as long as GPs and perhaps even psychiatrists or practice nurses are sort of leading the way with their time, so you know, so short, that it's probably going to stay with some of these quick, easy categories to think about.
Yeah, absolutely. Thank you both. Okay, I think we have 2 more questions. So we've got one here, which is, I've had an experience where I went to a GP with severe signs and symptoms with anorexia after relapsing in 2015 and was not initially referred back to eating disorder services due to other mental health problems, self-harm and trauma alongside. I know a lot of people with other mental health conditions alongside an eating disorder experience the same. Why is this? As it meant that eating disorder got worse for myself and others. Yeah, so essentially this person has not been referred back to eating disorder services because of other mental health problems alongside this. So yeah, is this a normal thing? I know this is something I've come up with through my volunteering. Actually, this is something that's come up. So yeah, I'd love to hear either of your thoughts on that.
Do you want to go, Greg, first?
Yeah, I can start. I suppose I guess there could be a number of reasons, and it's difficult to answer the specific question to this person's individual experience. But I guess I would be thinking around what was the biggest risk at that time. So, you know, obviously we're trying to improve people's quality of life and their well-being and their mental health. But the risk to life, I suppose, is probably the thing that people fall back on most. So if someone's self-harm and trauma were getting in the way of the eating disorder recovery or was threatening their life, then unfortunately we probably would refer people out. Equally, on the other side of the coin, some people who are very traumatized but their eating disorder is so bad that they can't engage with trauma therapy, we would then send them to work on their eating disorder. So it's about, I think, about stabilizing people first, so that they then can engage in the treatment. And that can get muddled when you've been referred once, and if you're going back, obviously waiting lists can be quite long, so it feels very disjointed.
Yeah, I agree with that. And I think from experience myself working with those with eating disorders, I think as clinicians you have to prioritize in that moment what that person needs most, and that might not be what that person agrees with what they need most. And it can be really tricky to make that decision. But if I was to say, as an eating disorder clinician for years, my bias automatically goes to eating disorders, and like we have to treat that first, and that's something that I'm conscious of and aware of. Whereas I might have the psychologist on my MDT might turn around and go, no, this, you know, so we'd have that discussion and say, if you start treating with CBTE, it's actually going to cause them more deterioration in their other comorbidities. So I think I would hope that's how it's done, and it's done professionally behind the scenes, kind of why that decision is made, and that you are informed of that, and that's why they've chosen to not re-refer to eating disorders and refer to something else, or focus on something else at that point, in the risk that the eating disorder treatment might actually cause because they're different pathways, like Greg mentioned at the beginning. They're completely different. They might fall under the same umbrella, but they're different approaches, they're different treatment pathways, and it might cause deterioration in another way as well. So I think a lot of professionals to balance that. Probably Greg has to do it more than I ever had as a nurse, but it's balancing what do we choose to prioritize right now. So hopefully that is fed back to the person suffering.
Yeah. And one really awkward, when you think about the logistical sense of things too, is that if it's within services, if a treatment is available there and then and another treatment isn't, then we might just have to grab it by the horns and take it while we can.
Yeah.
And it's not how it should be, but so that people don't miss out entirely, unfortunately.
Yeah, no, that's really helpful. Thank you both. I think that's very interesting to know, and it's difficult because sometimes the things interplay with each other and one thing causes another and it's a bit of a cycle, but it's good to know that that is how professionals are prioritizing behind the scenes. So we had another question, which is, what about support for a mature person with an eating disorder? So I'm guessing this is somebody who's on the older side. What kind of support can be helpful for them, I suppose, is the question there.
I guess there's a lot of conversations, isn't there, for early intervention, and it's a big focus in BEAT and in a lot of eating disorder services. Everything is like first 3 years, the Freed model, first 3 years, 18 to 25, CAM support. So I completely understand where that viewer is coming from. There's less conversations out there about those that have struggled longer, kind of maybe a bit more chronic when it comes to their eating disorder and out of that older age. And as I mentioned at the start, they do affect anyone of any age, regardless. So within BEAT, I guess you can still access the same support as anyone else from our kind of free available platforms through our helpline and our online support groups. Outside of that, you would still go through the same process of going to your GP first, accessing eating disorder community team treatment, I would hope, if it's available in your local area, or going through private, like Greg mentioned as well. I'm not sure if you have anything else to add to that, Greg, actually, you might know of.
No, unfortunately, I think it's a little bit how you summed it up, Kerri. I suppose we treat people differently. It would still be the same model and you'd still work in the same way. There might be other factors that person might be thinking of when they're thinking about who they want to be paired with, much like some of the other categories, people who have experience working with older adults or, as you said, more chronic sort of eating problems. But I don't know anything specific.
Yeah, that's perfect. That's really helpful. Thank you. I can see we've had a few more questions come in, so we're going to see how many we can get through. But apologies if we don't get through to everything. We are going to be sharing everyone's details, so if you want to connect afterwards, you can. And I did notice somebody asked if the webinar is being recorded. It is, so it's going to be going up on our YouTube channel, which is Happiful, and also on happiful.com, which will be there during Eating Disorders Awareness Week, so you can watch this back, and hopefully we're going to be emailing out the video to everyone as well. Okay, so let's move on to the next question, which is, can eating disorders run in families? I have an anorexic daughter, but also have a binge eating disorder myself. So yeah, that's a very interesting one. Do we find that eating disorders run in families? I don't know who wants to take this.
There can be genetic elements to it. I think it's hard. It wouldn't be the main cause or the main. We don't know all of that, but there can be genetic elements to it. Yes, I think they're completely complex mental illnesses, and there's a lot of varying factors that come into what might cause an eating disorder to develop. Genetics can be one of those kind of predisposing factors, but there's a lot of like precipitating factors and kind of, can't remember the other P word that we use at this time of the evening, that kind of keep them ongoing. So there can be genetic factors to it, yes. Greg might have more psychology answer to that.
So I would tend to look at eating disorders from like a biosocial model. So, a bit like Kerri said, so not that they are caused by genetics, but some people might have an influencing factor from their genetics, but other things such as social factors, learned behavior, ways of coping, seeing that from other people. I think it's important to not, I think sometimes with eating disorders, especially, sometimes we can want an explanation for it, but in much like a diagnosis, or when we don't have ownership of it, so such as my eating disorder, or it's because of my genetics, we then lose a bit of power about how we can change things and improve things. So I think it's just careful about how we think about the cause of this, obviously something we struggle with, but not having that being debilitating.
Exactly. There's so much more to it. It's there, as everyone here probably knows, they're so complex that you couldn't just put it down to that one thing. And the other factors that play a part in it need to be looked at in just as much detail, if not more, really, for treatment pathways.
Absolutely. Thank you both. Okay, so another question we've had is, following weight restoration and discharge from eating disorder services, there can be an increased anxiety and potential risk. Is this also something that could be explored for primary care training? So Kerri, I'll come to you with this with regards to the training that BEAT are offering. Is this something that's included in there?
Yeah, I would definitely think so. The training that we are looking to kind of get up and running later in 2022 for our current GPs is being put together by a really amazing group of clinicians who are extremely knowledgeable in eating disorders plus these areas. So I think it will definitely be considered, and I would think likely a very big part of that training. I haven't seen the training yet myself. I think what we're looking at doing is being able to provide the training package to universities, to kind of foundation programs, so they can make sure that they're utilizing it. So we won't be delivering it ourselves. We'll give them what they need to train and what they need to learn, and we'll be updating that regularly. So all these kind of ideas and kind of new things, we'll be able to update that training package regularly, if that makes sense. So that is definitely something that will be included.
Yeah, I think that would be great, because that's so true. Like, after recovery isn't a linear thing. It's not you've recovered, you're discharged, you're fine. I know for me personally, I've realized that anxiety was at the base of all of it. That's kind of what it was, and that's what I continue to live with, and that's what I continue to get support with and figure out. So thank you, Judith, for that question. That's super interesting. Okay, I think there's one last question. So that is there anything on the BEAT website to help with autism and eating disorders, or any other suggestions on autism and eating disorders and how this can be helpful for people, or any suggestions basically of support for those struggling with eating disorders and are autistic?
Yeah, this is something that has kind of been on trend the last few months, I guess, wouldn't be kind of top. We've got a lot of people calling the helpline with autism, a lot of people really just bringing up the conversation a lot more, which is amazing. On our website, I think if you were to put autism into the little search box, you get some stories of those that have experienced kind of outpatient treatment with autism. We are looking at what we can do for autism across BEAT at the moment. Our advisors are looking at being trained in autism over the next few months in a bit more depth, just so they can support people. There are a lot of books out there. I'm not sure if it's ARFID that you mean, or if it's kind of the more well-known eating disorders with autism kind of as well. If it is ARFID, we are looking at piloting services at the moment that are actually ongoing for carers, and we're looking, there's a lot of stuff that's happening in BEAT with ARFID and autism that we're hoping to be able to kind of publish and put out there over the next 12 months that we can roll out nationwide. But I think if you were to search on the website, there's not a lot, because eating disorders is kind of our main focus there. But on the pod, I think there is a lot more information through that. If you were to make an account and log in there, I think there's a lot more learning resources through there for carers.
There's some interesting stuff on the National Autistic Society website around adapting support for people with autism who have eating disorders, and they also talk about ARFID quite a bit. So if people go onto the autism.org.uk and in the search bar put in eating disorder, there's usually quite a few articles there.
Yeah, thank you so much both. That's so interesting, and it's definitely something I think it would be interesting for Happiful to look into as well. So maybe it's something I'll take to the team for us to look into.
Definitely, it's been talked about a lot more recently than I've ever realised, particularly the last 6 or 7 months. So I think it's becoming more and more known. So I think it's really important.
Yeah, absolutely. And we have had one more question, so we've got 5 minutes and we'll go through it very quickly. This is someone who has gone through eating disorder services and they feel like they've been given up on. They're 19 and they're going through a really tough time, and they're asking, how can I communicate and reconsider my therapeutic options because I don't want to be given up on? So have you got any communication tips if someone is struggling at the moment and maybe the team are not seeming to be willing to continue supporting them? I do want to say as well, please, to that person who has asked that question, please do take a look at the BEAT helpline as well if there is someone you want to talk to about this, because this is obviously a really tough thing to be going through.
So one thing, I suppose, it would be dependent, I guess, they're NG fed at home. I suppose one thing that they might want to consider looking into, I don't know whether it would apply because they're not under sectioned, is be whether or not they could have an independent mental health advisor. But perhaps having a look at advocacy services so that they could communicate that to their advocate, and then they would communicate to that person's clinician team on their behalf. So that might be one way of getting their needs heard and represented if they don't feel kind of like they're getting it across the way they want to.
Amazing. Yeah, and somebody in the chat has just said, yeah, I have an IMHA, really helpful. It's a really great idea. Thank you. Perfect. Okay. In that case, I think we're done. Thank you so much, everyone, for asking your questions and being involved in the chat. It's been really amazing to hear everyone's experiences and really appreciate it. So yeah, Greg, could you please tell everyone where they could connect with you online if they want to learn more about your work?
Yeah, so if you go to questpsychologyservices.co.uk, or you can find me on Twitter at questpsych, and you can chat to me there.
Perfect, thank you. And Kerri, how about yourself and BEAT?
So I think I've mentioned a few of them already. So beateatingdisorders.org.uk is where you'll be able to access everything that I have mentioned. I think from social media, on Twitter, Instagram, and Facebook, it's at beated. But on our website, you'll be able to access everything. Our helpline numbers will be there, our web chats, our online support groups, and the social media at beated if you need to contact us through that as well.
Brilliant, thank you. And if you want to connect with me, I am on Instagram, I'm at @catbluejay, and Happiful obviously is happiful.com. And if you are looking for more content around mental health and well-being, as well as a place to connect with professionals, so this can be therapists, life coaches, nutritionists, then I would recommend downloading the free Happiful app, because you can do all of that through there. And of course, you can also visit counselling-directory.org.uk to find therapists who can support you if you want to go the private route. But yes, thank you again so much, everyone, for joining us, and I hope you have a lovely rest of your evening.
Thank you so much.
Take care.
Thank you.